Okay, so I was going to do pancreas today, pancreatitis. You guys can, if you guys have questions about the respiratory stuff, I can also give you guys my number. You can text me if you guys have questions. To start, I was going to start by showing the anatomy, because understanding the anatomy of the pancreas actually super helps, like with understanding like the patho and like what's going on, right? Because otherwise you just kind of like have like pancreas exists somewhere. I don't really know what it looks like or what it does, but you know, and understanding it just makes it just way more easy. So first I'm going to just draw, you know, you have like the quadrants, right? The 4 quadrants of the belly here. So I'm just going to draw those real quick. Can you guys see this okay? This marker? Okay, so this is your sternum. And these are your ribs.
Mm-hmm. Oh, so I have nothing.
Did you guys do pancreas yet in class?
No, she's not doing it. She just did.
What do you mean you're not doing it?
She's not doing it in class. She recorded it for us to listen to.
Okay, so this will be good for you guys then.
Yes.
Okay, good. I was like, I don't know if they even want me to do pancreas, so that's what I'm doing.
It's on this test.
Okay, perfect. Okay, so rib cage. You got your liver. I'm gonna do a different color. Your liver's over here, and it's about like this. You know, this is the right upper quadrant. This is the right lower quadrant. Got the left upper quadrant and the left lower quadrant. Okay. So then you have, I'm going to do the front. So the stomach is kind of like here. The spleen is kind of over here. Then behind the stomach and the spleen, that's where the pancreas is. So I'm going to kind of do like a dotted line to show that it's behind, if that makes sense. So the pancreas is like partly in the left side, mostly in the left side, but also partially in the right side, but in the upper quadrant. Does that make sense? So I did it dotted so you can remember that it's behind those things. So it's loaded, it's behind the stomach and the spleen up there. So if someone's having pain, they're going to have it in the upper part of their abdomen, not in the lower parts of the abdomen. Epigastric pain is what they call it. And then under here, you know, you got your colon, right? And then your small intestine is all chilling in there. So that's where it is. For the anatomy of the pancreas, I'm going to kind of just erase that and just draw it over here. So the anatomy of the pancreas, actually I might need more space. Is it okay if I just erase this? There's a lot going on with the pancreas. So, you know, you have like your stomach. I don't know if that's not anatomically correct looking, but it's okay. And you have your stomach goes into the what comes right after the stomach?
Small intestine or intestine?
Which part though? Like the duodenum, right? So duodenum kind of goes like this. Oh, you guys are good. You didn't realize it was gonna be a test. Right in the middle of the duodenum, you have a little sphincter that connects to the pancreas. So the pancreas chills right here.
Okay, is that like the pancreatic duct or the head?
Yeah, I think they call it the sphincter of Oddi. I don't know what they put in your notes. If you have to even know this, I don't know if you really have to know the anatomy, but just like understanding how it works will help with the patho a lot more. So you have this little sphincter right here that connects to like the pancreatic duct, which goes like it goes all the way through the pancreas, picks up like all the digestive enzymes and the hormones that are produced in all the lobes. Like, you know, it looks like if you look at a picture of the pancreas, it looks like a corn cob, or because it's got like these, it's like yellowish and they have like these little lobes. So it looks like a thing of corn. So, you know, that they're producing the enzymes and hormones and it gets picked up and goes into the pancreatic duct. So it looks like this, pancreatic duct. Then you also have another branch of the sphincter that goes to the gallbladder. So this is the gallbladder right here. And then this is the common bile duct. So the bile comes down here, goes into the duodenum, and you got all the enzymes and hormones from the pancreas that comes down here and goes in here. So you can imagine if you have gallstones, right, and they start collecting and filling up here, the gallstones, if they block something right there, you can get into a lot of trouble because now you can't have any of the bile come through, and now you also can't have any of the pancreatic enzymes come through, right? So they're all blocked up in there. right? So this is why gallstones are one of the things that can lead to acute pancreatitis, right? A blockage, right? So what happens is that if you have a big gallstone here blocking the passageway, so it gets blocked, the enzymes, like the digestive enzymes, all get stuck, and the pancreas starts like literally digesting itself.
That's whenever the pancreatic ischemia happens.
Yeah, it can start getting necrosis, like, because it's like super painful, right? Because like those digestive enzymes are meant to like digest everything you eat, right? So it's really strong, right? And so like if it's literally like just sitting in there getting blocked up, you've got all these enzymes just like starting to break down your own pancreas. Very painful, right? Pancreatitis is one of like the most painful things that people can have, which is why like part of the treatment like is huge on comfort and pain relief. Like Dilaudid, we're talking like getting out the major thing, not some ibuprofen, right? We're getting out Dilaudid morphine to deal with people's pain because it's bad, right? So this is one of the reasons, you know, when I was saying the anatomy, like understanding like how the ducts work. So yeah, that's what.
How do gallbladder stones form?
Gallbladder stones, eating a lot of like, you know, fatty stuff. Diet is huge, like a lot of fatty foods. Not really sure like what else. They don't really go into it a bunch in the pancreas lecture because it's not really part of the pancreas. But yeah, mostly people that have really high fatty diets, like have really high cholesterol, they just start to build up the gallstones. People that are like super healthy, vegan, vegetarian, they never get like gallstones unless they have some kind of weird like thing where they don't have the ability to digest things. Like people get kidney stones because they produce too much calcium and different things like that. So unless there's like something else going on, typically it's from diet. Okay. So anyways, and then I don't know if you guys have to know this or not, but this is called the tail of the pancreas. This is the body, the middle part, and then this is the head. I guess it's more of the rounder section, this portion of it, right? And this is like the skinnier part, so it's the tail. I don't know if you guys have to know anatomy or not, but I think understanding the anatomy helps understand a little bit better of like how it works. So what are some of the functions of the pancreas? We'll talk about that, because knowing what it does normally when it's healthy will help you understand like what's wrong with it when it's not working, right? So number one, we talked about it, is the digestive enzymes, right? So digestive enzymes, and then there's 3 types that you need to digest. You guys haven't gone over any of this, you don't know. I was about to ask you, but you haven't even had a lecture on it, so forget it. So you have carbs, proteins, and fats in your body, right? You probably took a nutrition class however long ago to get into the nursing program. So in order to break those things down, you have to have 3 different types of enzymes. So for carbs, you need amylase.
Is it not amylase, lipase, and
yep.
protease?
Well, carbs is amylase, the fats is the lipase, yep. And I don't remember about the protease, but for this, the pancreas produces what's called trypsin. You'll see that in your notes, and that's for the proteins. I think protease might be stomach related, but don't quote me on that, but this is strictly the pancreas. So this is for protein. And these are part of what you call the exocrine functions of the pancreas. The pancreas has 2 functions. One is endocrine and one is exocrine. So the digestive enzymes, all of this is considered the exocrine functions, and I'm not really sure why it's called exocrine, but that's what it is. And the endocrine, you guys know, is all like hormones, right? So the endocrine is like the insulin and the glucagon that you know already from like diabetes, which I think you guys have learned already last semester. So the endocrine functions is the glucagon and insulin. And do you guys remember what secretes insulin? It's okay if you don't.
The beta cells.
Yep, beta cells. The beta cells do insulin. And who remembers what glucagon?
What is the islets of Wonga called? Does that mean into the pancreas?
Probably.
Okay.
You can Google it and let me know.
Okay.
Yep. I didn't see it in my notes anywhere, so I don't know if it's important for this. The alpha cells are what do the glucagon. They may need a refresher on how insulin and glucagon work. So glucagon is helpful for when glucose is almost gone, right? So when you have very low levels of glucose in your body, like hypoglycemia, glucagon will kick in, right, to help raise that. It helps me remember glucose is almost gone, glucagon. And insulin is secreted when your blood sugars are high, right? And both of them work together to kind of keep you in a nice equilibrium, keep your blood sugars where they need to be. That makes sense? So these are the endocrine functions, and the digestive enzymes are the exocrine functions. So if they ask about endocrine and exocrine, don't get confused. Those are just the two things that it does. Does that make sense? Now, in any type of pancreatitis, both of these are going to get impacted, right? Because they both come down the what do you call it? The pancreatic duct, right? So if your pancreas isn't able to function, right, it's just not able to produce because it's getting necrosis or the fact that it's blocked and the stuff can't come out, you're not going to be having these enzymes into your stomach and in your body that you need, and you're not going to be having these that you need either. So what kind of signs and symptoms do you think that you would see if you're not getting either one of these? Yeah, so your blood sugar is going to be all over the place, right? Like it's high, lows. They're probably going to be needing exogenous insulin. So like even if they're not diabetic, they're going to be functioning like a diabetic in that moment because they're not going to be able to have the insulin. So having blood sugar checks for someone with pancreatitis is really important, even though they may not be diabetic, right? So that might be something you might want to explain to the patient. They're like, why am I getting my blood sugar checked? I'm not diabetic. You hear that all the time. And it's like having to explain that your pancreas is the one that is responsible for helping regulate that. So since their pancreas is in distress, their blood sugars are out of whack. It's not necessarily that they're diabetic. It's just that their pancreas can't do its job. Does that make sense? Mm-hmm. So blood sugar checks is part of a patient care interventions that you definitely want to make sure to check because it can be who knows what. For the digestive enzymes, again, it's going to be digesting itself, kind of just sitting in there if it's blocked with a blockage, and that's going to be extremely painful. There's a ton of symptoms, so I'm not going to, unless you want me to, I can either list them or just kind of talk about them. I don't know if you want to see them visually. It's up to you. Do you want me to write them down? Okay, I'll write them over this side. I think I'll stick with the blue color. I think it shows up better. Okay, so signs and symptoms, there's several because there's a lot going on. So we talked about what kind of pain will you be feeling? What's it called? Epigastric. Pretty sure that'll be a test question. Epigastric pain. This is also in your notes. The pain will be worse when you're laying supine rather than like on your stomach. So when you're laying on your back face up, it hurts worse. What's like the sign and symptom that everything has when you have a problem? Nausea, vomiting, but especially with this because this has to do with digestion, right? So you're not digesting well, nausea, vomiting, right? So nausea, vomiting for sure. The other thing you might see.
I had shoulder pain.
You had shoulder. Did you have this?
I had issues with my gallbladder blocking.
Oh, did you? Yeah. Yeah. So sometimes they have to like figure out is the issue originating in the pancreas or is the issue originating in the gallbladder? Yeah, they do say that the pain can radiate to different parts. I didn't memorize all those different places.
That's more gallbladder than pancreas.
Okay. Yeah. Abdominal distension. That can be if you're starting to develop some like peritonitis, where like those enzymes are starting to seep through into the peritoneum where they shouldn't be, irritating the peritoneum because those enzymes are really strong. They're like really like, irritating. So if it leaks out into, the abdominal cavity, you can start developing peritonitis, having abdominal distension, like the guarding, having we always palpate the abdomen, extremely painful. So we can have abdominal distension, ABD. Hope you can read my handwriting. Another thing you might start to develop is jaundice. Anyone think about why that might be? Yeah, so it's directly related to the blocked bile duct and the whole like bilirubin, bile, like liver stuff, which I think you guys did before, like last test. It interferes with all that whole metabolism, right? So the jaundice are related to the blocked bile duct. The other thing that you might see, which might be weird, is kind of like shock-like symptoms, hypovolemia, tachycardia, hypotension, and that's because these digestive enzymes, as they're like sitting in the pancreas and everything, they can start causing bleeding to occur because they're very strong, right? And it can cause bleeding internally, and then you can start bleeding internally, having symptoms like shock, where you start having hypovolemia, all those different things. So I'm just going to put down arrow BP and then up arrow heart rate, shock, and I'll put shock like that. And that's obviously a worst case of pancreatitis. These are just possible things to keep your mind on when you're looking at a patient. There's two specific, I guess, telltale signs you would want to look for to be like, oh, yeah, that's got to be pancreatitis. One's called Gray-Turner sign, and one's called Cullen sign. So Gray-Turner sign is where they start having bruising on like their flank right here. So like this, like you'll see in the PowerPoint, they have like a picture of a patient with like a big bruise, like right on their flank right here. That's the Gray-Turners. And I remember that one because like when you turn, you're on your side, right? And then the other one, Cullen sign, is bruising right around the umbilicus, the belly button. So trying to differentiate between those two, because like they seem very similar. As I just remember Turners is because you're turning on your side. So I'll put Gray-Turners and Cullens. And that's just the bruising. We talked about, the sugar, the blood sugar issues. So I'll put blood sugars. Talk about that. And this one might come as a surprise, but as pancreatitis starts to worsen, people can start to develop pulmonary issues. Things like ARDS, which is part of this content that you guys are learning. And that's because these enzymes, like when there's a bunch of them blocked up like that, the pancreas is still like producing it, right? But they're just kind of like blocked. So they're like just spilling out where they shouldn't be. And that's, causing a lot of pain. Is they can start entering into the thoracic cavity through the lymph nodes, right? The lymph nodes, carry fluid throughout your entire body. So if the lymph nodes carry these enzymes through the thoracic cavity, be super irritating to the lungs. You can develop ARDS and pulmonary complications. Obviously, these are like, things that are worsening from pancreatitis, but just keep in mind as potential complications, if that makes sense. So I'll put ARDS/pulmonary issues through the lymph nodes. And then the last one I have is paralytic ileus. Does everybody know what that is? Your bowels stop moving. And that's again from the peritoneal irritation. So if those enzymes leak into the peritoneal cavity, causing irritation, inflammation, it can cause the intestines to kind of shut down and not move. So a lot of issues, right? The pancreas, remember the anatomy, sits pretty high up. So it's right next to the lungs, and it's right between the lungs and the intestines. So depending on which way the enzymes are going, up or down, it can cause problems. The patients that I've seen in the hospital with pancreatitis typically have like a drain, to kind of drain some of those enzymes out, and they smell so bad. Let me tell you, like it's like bright yellow, and like I'm just like, wow, it's so much too. And it's honestly, these patients are so pitiful because they're in so much pain. It's really like, oh, heartbreaking. So let me write that one down. Paralytic ileus. I don't know if you guys want to take a picture of that. If your phone, if it really can show up. Does anybody have any questions or anything unclear about any of this so far? Everything makes sense? Okay. Okay, I'm going to erase this side. Are you ready for erasing? Next, we're going to talk about like diagnostics. So you suspect that someone might be having pancreatitis just because they're having lots of these weird signs and symptoms. You're like, okay, how do we know for sure? There are certain tests that you can do. The obvious ones are you can run an enzyme test, like you can take an amylase level or a lipase level, right? And that's pretty good common sense, right? And do you guys think that those are going to be elevated or lowered in the case of pancreatitis?
lowered because it's not releasing? They're gonna be elevated.
Yeah, they're gonna be elevated because they're blocking up, right? And they're not being able to come through. Yeah, and so they're producing more and it's irritated, right? And it's what's causing the pain. So both of these are gonna be elevated in the case of acute pancreatitis. Does that make sense? And that's what's building up and digesting itself because there's too much of it. That makes sense? Great. White blood cell counts. Do you think that's going to be elevated or decreased? Elevated, right? Anytime there's like inflammation or irritation or anything, these guys always shoot up. And obviously this in of itself isn't an indicator of peritonitis. I mean, pancreatitis, but it helps to put the whole picture together, right? White blood cell count in and of itself doesn't diagnose anything, but it just helps to have the whole picture. Glucose levels are going to tend to be on the high end, right? Because they're not able to produce the insulin. If a person's still eating normally, they're going to not have their blood sugars be super low, right? They're going to continue to get higher, right? So glucagon isn't going to really need to do anything because if people are still eating and everything, then their blood sugar should be normal or high. And so remember checking, they might need to get insulin temporarily. The other thing is calcium. Calcium levels are going to be super wacky. So they're going to be low. And this is apparently like one of the telltale signs. That's like one of the hallmarks of pancreatitis. And I'm not sure exactly the reasoning behind the patho of it. It's been a long time since I've been in adult 3, but I just remember that this one was like one of the telltale hallmarks that the calcium is going to be low. And do you guys remember what the names of the signs and symptoms of having low calcium is?
Oh,
yeah. Yep. Trousseau's and Chivas-Sex. I don't know how to pronounce that. I'm just going to put the C and T sign. I always get them mixed up which one's which. Chivas-Sex, I think, is the cheek one, right? CH, yeah. And then the Trousseau's is the arm curling up. So looking out for those things with patients with pancreatitis. So these are all things you can start to look at to kind of see, okay, is this person really having pancreatitis or like what's going on? Because like with GI pain, it could be so many different things, right? Like there's so much happening. Like you got a stomach, you got a liver, you got a spleen, you got kidneys, you got intestine. So it's like, what is it, right? So like these are a couple things that are like going to be different. Like amylase and lipase, that's like unique to the pancreas. This isn't unique. This is, but it could be related to something besides pancreatitis. This one's going to be a hallmark. The other things you can do to kind of diagnose is looking at the AST and ALT levels. These are related to the liver, but again, it kind of comes back to the bile situation, right? The bile all plays a role with the bilirubin and all that stuff. So these are going to be elevated as well, just because there's the stress.
Do you know the normals for amylase and lipase, or do you need to know?
I don't think you need to know that. Yeah, they're just elevated. I don't know. I can look it up on here. They have their levels on here. I just didn't write them down. If you want to know, my notes say serum lipase normal levels are 25 to 125. So I guess above 125.
For what?
Amylase.
Oh, okay.
And then normal limits for lipase is 0 to 110. So above 110. And you should know white blood cells. I don't know the ALT and AST.
They're at 30. They're 0 to 35. I think they're in
I don't remember.
normal life range.
You can Google it. I doubt that'll be on like a specific test question. I don't know. Unless they want you to memorize those numbers. I don't know. Let's see if it's in your notes in your PowerPoint. If she doesn't mention them, I wouldn't worry about it. There is a thing called Ranson's criteria, and my notes don't say like what the criteria is. It just says that it's a thing to use to determine like how bad the pancreatitis is to see like predicting mortality. So typically, like when someone comes in, they kind of assess all these different things and they give them a Ranson number to determine like their mortality level, but that's all my notes say about it. Like it doesn't say what the criteria is. So I don't know if yours will be more expounded upon, but just if you hear the Ranson's criteria, just know that it has to do with like predicting mortality. Like what's the likelihood of them dying from this? That makes sense? And it's spelled Ranson. It's like ransom, but with an N instead of an M. Okay. The other diagnostic you can do is with an endoscope. It's really interesting. They take a scope, it goes all the way through the mouth, goes down through the stomach, goes down through the duodenum, and then up into here. So down the mouth, into the stomach, into the duodenum, and up here to kind of look around and see what's going on, see if there's like a blockage or if there's a stone or whatever. So that's something they can do, an endoscope, and that's pretty much it for diagnostics. Any questions about those?
You said AST and ALT is altered. It would be up.
Up, yes.
Okay.
They will be up.
You said those are down.
I'm sorry?
There are no specific reason
Um,
why those be down.
Yeah, I don't think so. I think usually whenever the liver is in distress, they go up. So I don't know of a case of them going down. I don't know. Maybe they're just not producing it for whatever reason.
But that's a good thing.
Yeah, I don't know.
And here's I've never seen a low AST or ALT.
Well, there you go.
I've only seen elevated.
There you go. Low is good, right?
I've never seen a low.
What do you do?
I started off as a rad tech. I'm an LPN. I work in oncology office.
Oh, perfect. Awesome. So I'm sure you see pancreatic cancer too.
We do.
Awesome. So maybe if you guys have questions, you can ask her about it. Huh?
We do already.
Okay, so we good on this? Diagnostics, do you have anything to add? No? Okay. You had a question? Oh, you raised your thumb. Okay, not your hand. Perfect. Okay. Then we're going to talk about treatments, interventions, what to do about it. And I'm going to use red because a lot brighter. Yes. Okay. Treatments. This is pretty much a treatment for everything. Fluids, right? Help flush everything out. Also, remember again, some of the signs and symptoms are like shock-like, low blood pressure, high heart rate, low hypovolemia. So this will help balance that out. Fluids are pretty much always given unless it's like a CHF situation. People always get fluids. Pain management is the big one, right? Dilaudid, morphine, all the good stuff, right? This is the stuff that you're going to give them. Calcium replacement. Remember, because one of the hallmarks was low calcium. So giving them calcium to replace that. Obviously, blood sugar checks. Monitor that. We talked about that already. Now, things that are directly going to help are giving them antihistamines and anticholinergics, which will directly impact the pancreas's release of the enzymes. So it will help decrease the amount of enzymes that are being produced, which will help calm down everything and have it not be so painful and have it stop like the harmful digesting of itself. So antihistamines and anticholinergics.
Increase the amount of enzymes produced.
Mm-hmm. Decreases enzyme production. The other thing that these people are probably going to be on, at least for the short term, while it's in its acute phase, is they're going to be NPO. Can you guys think of why that might be?
Because they need surgery, gut rest.
Well, they might need surgery, but gut rest is another one. But the other thing that's huge is that your pancreas, when it's functioning normally, is it releases these enzymes when you eat, right? It's like, we sense the presence of carbs, fats, and proteins, time to secrete amylase, lipase, and trypsin, right? So if you're NPO, you're going to prevent your pancreas from being triggered to produce more, right? So at least in the short term, obviously that's not like a solution for long term if someone has chronic pancreatitis, but in the acute, like short term, having them be NPO for the reason that you said they might need surgery, giving them gut rest and to prevent the enzyme release. Does that make sense? Obviously that's not going to be maintainable for like weeks on end, right? So if they start getting to the point where like they obviously need nutrients, is they'll switch them to like TPN, right? To bypass the gut, right? Just to give them the nutrients they need, just bypass everything in the GI system. Yeah, so surgery is another treatment that hopefully people don't have to do. Usually in the acute phase, it can resolve itself if you get treated. There is no cure for chronic pancreatitis once you kind of develop, kind of with anything, like once you develop something chronic and it's like damaged permanently, you can't undo it. So it's early treatment, just kind of like acute versus chronic renal failure.
With blood glucose, is that also saying that we would give them insulin for treatment as well?
I mean, yeah, if their blood sugar is high, yeah, because the problem is that their pancreas isn't producing it or it's not able to get through, right? So either way, they're going to need insulin to get them over this hump until their body kind of calms down and is able to back to function again. So that's often very confusing for patients. They're like, why am I getting insulin? I'm not diabetic, and having to explain that, like, we know you're not diabetic, but like your blood sugar is really high because your pancreas can't do the insulin right now. So that's, you'll hear that all the time. Patients are very confused because they don't understand. So the type of surgeries that you might have is there might be an abscess that's forming on the pancreas because of the enzymes. There might be some necrosis from, the buildup. They might need to take out the gallstones. I had a student today in fundamentals see a surgery of gallbladder removal and gallstones removal. So any of those reasons might be a cause for surgery. So hopefully they don't have to have surgery, but sometimes you do. Any questions about any of the treatments? No?
Do they do TPN?
Oh yeah. If it ends up being like a longer situation, like people can be NPO for like a couple days, but if it's going to be more long-term, you can't just be like, hey, you don't get to eat ever again,
Ever end up doing like a feeding tube, like a GJ tube?
Yeah, they also can do that. It kind of just depends on like how long they expect them to be there or how bad it is. Like if it's really bad, they might just do TPN and just give the whole gut a break, right? Especially if they have like peritonitis and something like that, they'll just skip it because they have the paralytic ileus. Doing a GJ tube isn't going to help, right?
Is it usually they can leave you NPO for like 5 days?
I don't know how long they can leave someone NPO. That's a great question, actually. I'm not sure like what the standard of care is for that.
Your body starts to break down itself.
Yeah, I would just assume that the doctor is looking at the whole picture, like, okay, like how long could this person realistically be without food? And if they're having a bunch of these extra signs and symptoms, like they have like paralytic ileus and the abdominal distension, they're probably gonna be like, you know what, we're not doing a GJ, we're just gonna do TPN. Whereas if it's maybe not that serious, maybe they will do a GJ. You guys know what a GJ tube is? It's where they skip the duodenum. They have like a tube, essentially that like, so they have, how like people have like the peg tube. So it's like, it looks like a peg tube going in, right? But then they have like a really long catheter that goes all the way down into the jejunum, which is, just down here, right? So that the food, instead of sitting in the stomach, like usually peg tubes, they deposit the food here, right? It'll go down this tube all the way through to the jejunum and just bypass the duodenum where the bile duct is and everything. So it can give the stomach and the duodenum a rest. Does that make sense? Because the presence of food in the duodenum is what triggers the release here. So if it's just bypassed all the way down here, it can just skip that part and go down. But if you're having, again, a lot of the other GI symptoms, it might not even be enough. You might have to do TPN. Does that make sense? I've had patients that just have GJ tubes forever because they just have constant problems. So they just are always on a GJ. So does that make sense though, the GJ? Like it goes from the G, huh? Yeah, for gastro, G, and then the J is for jejunum. Okay. So it goes, the tube is going into the stomach, right? Just like a normal peg tube. But what we don't see underneath is that there's a little catheter that goes all the way through. So whatever tube feed you're giving them doesn't get deposited in the stomach, it gets deposited in the jejunum.
Those would be put in surgically. Your regular feeding tubes, like a little Mickey button, you can change those out.
Yeah. If someone's peg tube pops out, you can pop it back in, but you can't like pop all that back in. You're not going to know what you're doing. So does that make sense? It kind of just depends on how bad the patient is, different options. So this is acute pancreatitis. Any questions? Anything not make sense? So you guys don't even have notes or anything to look at?
I printed off the PowerPoint slides and I took some notes out of the book myself.
Was there anything I missed or didn't clarify? let me know if you think of something.
Banana, we're into, she did alcohol withdrawal in between.
Oh, I don't even have like anything on that. Alcohol. I don't even remember having that as a topic.
Yeah, it was a whole page of alcohol withdrawal.
There's something new that they're adding.
There are here,
Yeah, I don't have anything with this.
there's the slides.
Yeah, was that on class?
I printed it on the board.
All right, well, let's do chronic, because that'll be quick because it's very similar to acute. And then we'll do cancer, which is also pretty easy, and she can share her infinite wisdom. And then we'll see where we're at from there.
Everything we just did chronic. I mean,
Acute.
everything.
Yeah, I mean, honestly, a lot of it's going to be like
This was
if you look at acute renal failure and chronic renal failure, a lot of it's the same. So you'll see like a lot of it's similar.
But like the diagnostic tests.
Yeah, I mean, all that stuff. Honestly, acute is just quick and fast. It happens suddenly, whereas chronic is slowly building over time, right? And can you guys think of what probably like the number one cause of chronic pancreatitis is? Alcohol. Yeah. So alcohol is the number one cause of chronic, right? Like you're just slowly poisoning your body over time, right? So chronic, number one, alcohol, ETOH. A lot of the stuff is going to be the same, but you're going to have a few different signs and symptoms that you won't see in acute, because in acute, it happens suddenly. So it doesn't have time to develop some of these other signs and symptoms that the chronic ones have, if that makes sense.
Sorry, what was the number for the hashtag?
Oh, number one. Thank you. Hashtag alcohol. Number one cause is alcohol. That's what I meant to say. Okay, so some of the signs and symptoms that are going to be different that you will see in chronic but not in acute is steatorrhea. You guys heard of that? Yeah, steatorrhea. You won't see this in acute just because you don't have time for it to get to this point, right? This is something that kind of like takes a while to like develop. So like when someone has acute, they kind of just like they start developing it really quick. So a lot of the signs and symptoms that you see in chronic, you won't see in acute because it's just your body hasn't had time to get there. So yeah, steatorrhea. What are some of the qualities of steatorrhea?
It's like gray.
Yeah, pale or clay colored.
Yeah.
What else?
It floats.
It floats. Got some floaters. Sorry. Someone said oily.
Yeah.
What else? They call it fatty. I don't know why. Whatever. And then the other thing is that it's just especially foul smelling, like more so than usual. And all of this is due to fat malabsorption. And remember that like the lipase, the amylase, and all of that is inhibited. And so especially like the lipase, which just helps to digest the fats, are getting messed up. And so you're not able to absorb it very well. So you'll see steatorrhea with decreased fat absorption. You'll also see like malnutrition, right? So people start losing weight because again, they're not absorbing fat. It's the fat malabsorption. And I don't know why specifically fat is targeted over carbs or proteins. It just is one of those things that just is. So along with the steatorrhea, you'll have like malnutrition, losing weight. You'll see that too with like pancreatic cancer as well. So weight loss. So when you feed these people to like kind of boost their nutrition, you're going to want to give them high calorie, like high carb and low fat, because they can't absorb the fat anyways, and it's all getting pooped out in steatorrhea anyway.
What about protein?
I'm sure that proteins are helpful, but they specifically target the high carbs because your brain, okay, so your whole body uses all of those for energy, but you're like for the energy for your cells in your body, like your body can convert proteins to glucose for energy, the ATP cycle and all of that, but your brain has to have glucose. Like without glucose, like you go into like diabetic coma, right? So like glucose is just really important because without it, like you can literally just go and have a coma. So I don't know. I'm sure like giving them protein is normal, but you don't want to give too much protein because then you run into the problems with like, the protein clogging the kidneys, because too much protein is harmful for the kidney to filter. So high carbs is to help keep their energy up, to keep them, because they can turn the glucose into energy that they need. Were you going to say something?
I was gonna say, I thought that like proteins, a lot of them will break down into fat.
That might be true. But my notes just say like having high carbs and low fat, specifically. I don't know specifically what they say about protein. But yeah, the body's clearly not absorbing the fat. So there's no point in giving it to them, So weight loss. So this person might start to develop diabetes, like an actual like diagnosis of diabetes, right? Can you guys think of why that might be?
They have no answer.
Well, you're damaging the pancreas, right? Like you're actually like physically damaging the pancreas now. So like the pancreas is becoming unable to produce insulin, right? So it's not an acute thing where it's just like the pancreas is like inflamed right now, but it's actually like the pancreas is like damaged chronically. And so like it's not going to be able to produce it. So they develop diabetes because of, probably from number one, alcohol. So this is actually like a diabetes that's unrelated to like eating a lot of sugar or like being obese. So you can have diabetes from chronic damage to your pancreas without having like, an eating problem or obesity, if that makes sense. Because, most people, when you think of diabetes, you think of like, oh, you're getting insulin resistance, and that happens in the cells, right? So like the problem isn't with the pancreas. The pancreas is fine. The pancreas is producing insulin, no problem. But it's that the individual cells in your body have become so resistant to insulin because it's constantly inundated with insulin all the time because your blood sugar is always so high because you're just constantly eating all the time that your cells just aren't responsive. So it's both is a case of diabetes, but there's just different reasons, right? So it's kind of more like diabetes type 1 in the sense that your pancreas isn't producing it, right? But obviously diabetes type 1 you're born with, and it's just because your beta cells just are not working, they're just broken for whatever reason. Whereas this one, you broke them from abuse, if that makes sense. Does that help kind of clarify? So you might get a diagnosis of diabetes, which wouldn't happen with acute, right? Because once the pancreas heals itself, it's back to normal. And then the last one is ascites. Do you guys know what ascites is? Who wants to tell me what it is?
Third spacing.
Yeah, it's just, those people that have they just have like these huge bellies, but everywhere else is normal. It's like, why? And it's just because that constant chronic irritation over time is just kind of like just staying there, right? Like the peritoneal irritation from like the chronic irritations of the pancreas just chronically developing. They just have like this chronic ascites situation. So they have like the ascites there, the fluid trapped below. So that kind of makes sense, like why you'd see these with the chronic and those more with acute. Now, obviously there's going to be some overlap, but like they're a little different just because one happens quickly and one takes time to develop over time.
So pretty much the acute is mainly because the gallstone clogging, the duct being clogged up.
Yeah.
Chronic is something that you were doing with alcohol consumption.
Yeah. The other thing I didn't mention earlier was it could also be a tumor. It doesn't have to be a gallstone. Like if you develop
just
a tumor.
something blocking the duct, pretty much.
Huh?
Is it just something blocking?
Yeah. If you have a tumor that's like pressing right there, like and compressing it, it would look it would present just like a gallstone, right? So that would be another reason. Alcohol is another reason. You can have like someone can get super drunk, super like toxicity and go into acute pancreatitis. And you can also like over time just constantly drinking leads to chronic as well. And the other cause for an acute was just an autoimmune situation where the pancreas is attacking itself. Autoimmune, your body can attack whatever it feels like attacking itself, right? So if people with autoimmune thyroid, they start attacking their own thyroid, and now their thyroid isn't making the T1, T4, and all that stuff. So I'm just focusing on like the things that you'll see more of, like the gallstones, maybe a tumor, maybe for acute. The chronic, there are other reasons. I think the notes mention them briefly, but like main reason is chronic alcohol use. But they also make sure that like not to assume that someone's an alcoholic, because there are people that develop chronic pancreatitis that aren't drinkers, right? So it's like not all people who have lung cancer are smokers, right? It's the number one reason, right? But it's not guaranteed that someone's a smoker if they have lung cancer. So a lot of people, you know, feel insulted or offended because people come in, like doctors come in and they assume like, oh, well, you drank. It's like, I've never drank in my life, and they feel like offended. So just not to like go in with that attitude, you know, just give someone benefit of the doubt. So that's pretty much that for that. The last thing is some treatments, which are going to be very similar to the acute. You know, pain management is still high up there. For these people in chronic, nutrition is going to be more of an issue because, like, you know, if you get sick for 5 days, your nutrition isn't going to plummet that fast, and like you're not going to be wasting away after like 5 days of not eating right. But if you have chronic malabsorption and like, you know, digestive enzyme issues over years, like your malnutrition level is going to be way worse than over a couple days for acute, right? So nutrition is a bigger issue. So yeah, that's what I was saying about the high calorie, the low fat.
In her side, she has high protein too.
Does she? Okay, perfect.
It says high calorie, high protein, carbs, and low fat.
Perfect. There you go. Mine was a little bit different, but mostly are the same. Yeah, that's pretty much it. The other thing you might give someone is enzyme replacement. If they're not able to produce it because their pancreas is just so scarred over and, you know, calcified and it's not producing anymore, you can get like synthetic and enzyme replacements to help with digestion and things like that. And I don't know how much information they give on that.
She gave us this paper.
Because I don't have any of that.
You
So
want to look at it? It's just, it was just a printout online about enzyme replacement. I can read this aloud.
enzymes should be taken with all meals and snacks, which makes sense because you don't need enzymes if you're not eating. Swallow the capsules whole, blah, 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 blah. Don't take it with hot drinks, apparently, because it will neutralize the enzymes. Kind of like heat can alter proteins. Like when you cook an egg, you alter the protein. It's not going to go back to a yolk. It's not going to go back to a runny egg. Blah, blah, blah. Spread the capsules out as you eat. Don't store the capsules in hot places, again, with the heat destroying them. When to not take them. They only work when they're taken with food. They don't need to be taken if you have only a splash of milk.
With only a splash of milk, including tea or coffee.
Fruit squashes. I don't know what a fruit squash is. Or fizzy drinks. It literally says that.
Doesn't say you're supposed to take them with milky drinks.
I don't. Maybe saying it's only like if you have a little bit, like a little bit of creamer with your coffee. They're saying like that's not enough to need it. You know, people that are like, what is it? People that have like lactose intolerance. Mm-hmm. They don't need to take their, and you know, people take enzymes for that. Like if you just have a little bit of creamer in your milk or tea, it's not gonna hurt you. Small amounts of fruit. Small amounts, basically small amounts of stuff. You don't need it. Moral of the story. What if you can't swallow the capsules? Open the capsules and mix the granules with cold stuff like smooth applesauce. What?
That sounds yummy.
Yeah, probably delicious.
Did you print this out? Yeah, it's on.
I did not receive this when I was in school, so I'm winging it. Basically, it has to be mixed with something cold because it will get deactivated if you mix it with anything hot, is the moral of the story. Don't chew them. I don't know why anyone would want to chew that. They can get stuck between your teeth or dentures and cause mouth ulcers because they're enzymes breaking stuff down, right? So if they get stuck in your mouth, it's going to start breaking that down. This is really, there you go. Do you guys all have this? Okay, highlights. Take it when you eat. If you're eating very small, you don't need it. Mix it with something cold and don't chew it. That's what I got from this.
Yeah. Here you go. And so the purpose of this, it was to replace what your.
Yeah, I mean,
replacement.
Your pancreas can't make them, so the capsules are making it for you. Any questions?
Is that for like over the counter or you need a prescription?
No, you need a prescription.
Okay. They're not like not something they compound. It's just a sales.
I don't know. I not the pancreas person. she's the pancreas person. Well, the cancer person, I guess. All right, so let's look at pancreatic cancer. I didn't have a ton of that stuff in mind, but if you have anything to add, please share.
The only thing that she gave us was a handout to be completed when we come to class. And
We were confused because it said that it was Christian.
Oh, but it was me.
I'm here.
And her time is 2 to 4, but it's a 1 to 3. I don't know. I'm not sure how that got mixed.
I'm always 2 to 4 because I get out of fundamentals clinicals at 1. So the fastest I can get here is like 1:30. So
I'm sorry for the confusion. I don't know.
You know what helped clear it up? If you brought in your test and let us review it, like let us review your question.
okay, so resuming, we'll start with pancreatic cancer now. Pancreatic cancer is really not that bad. What's this?
This is the only thing that she gave us.
Pancreatic cancer. Let me start with this first and then come to this.
Yeah, no, that's just how she
Look at
this is out.
Okay, so pancreatic cancer, they don't exactly know why for sure it happens. There's like some kind of genetic part that can come into play. Obviously, alcohol is a big one, huge one. Chronic pancreatitis that we just finished talking about, like left to its own devices, can lead to pancreatic cancer. Typically, as you get older, you're more at risk for any type of cancer, including pancreatic cancer. Typically, you'll see like African Americans tend to be more at risk for whatever reason than any other racial demographic for pancreatic cancer, and males more than females. So you're nodding.
That's it.
That's it.
Males. Males more than females.
I know, that's just one of those things. Their diet or their drinking, one of those two. I guess that's true. Stereotypically, men tend to drink more and eat worse, but they don't have as much body image issues as women do. Huh? That's just a stereotype, right? But you see it played out. They say diet is a big part of it. Diet's high in red meat, processed things like bacon. So we're in the South. A lot of people eat bacon. So you're going to see a lot of it here. You could also see it from any just kind of long-term exposure to chemicals and pesticides, but that's really any cancer if you have long-term exposure to harmful chemicals, right? You want me to write this? I mean, most of these are like, I can write it. These are all risk factors. These aren't like hard and fast causes, right? Because obviously if you're a Black man, that doesn't mean you're going to get pancreatic cancer. It's just a risk factor, right? So I'm going to call them risk factors.
On the last test that you did, or like another one, when I was in the test, I just remembered you writing on the board, and then I got the question right.
Oh, okay.
So it just helps when I see you do it.
No, that's perfectly fine. So increased age, obviously that's pretty everything. Men, African American, alcohol, obviously. Chronic pancreatitis, left, untreated. Chronic pancreatitis, what else did I say? Red meat, so, and highly processed things. Just honestly, like she said, just a bad diet. I'm going to put bacon here because that was specifically mentioned in my notes. And then chemicals, right? Toxins. Can you even read this? I don't know if it's legible. Yeah. Although I feel like some doctors' handwriting is way worse. And then the other one was just like hereditary, genetic. Sometimes people they do everything right, but they still get the cancer because it was passed down. Wasn't that, who was that guy, that biker, Lance Armstrong? Didn't he, what did he come down with? Some kind of cancer, wasn't it?
Testicular cancer.
Was it?
Wasn't it?
I thought there was a story that he was like, or was it heart something? Because he was like trying to get in shape because his dad had something, but he still got it anyway, even though he was super healthy.
Oh, Lance Armstrong just got fired because of dope.
Yeah.
Or maybe I'm
He
crazy.
was EPO and.
Okay, well, whatever it is, there's some story.
Didn't have cancer. That's
Wasn't it?
why they had
It was
really
testicular
strong
cancer.
Okay, yeah, live strong, right? I don't know. Anyways, the point is you can be super healthy, and if your genetics are against you, that's just how it is. So all of that to say that. So yes, it is written down now. Now there's a couple things they can do, like surgically, with the pancreatic cancer situation. They can obviously do a total pancreatectomy. That's how you say it, removing the pancreas. What can be some potential problems with that? Obviously, insulin. You're now a type 1 diabetic essentially, right? Because you have no production whatsoever. So you're going to have to be on, insulin and all sorts of stuff for life. What did you say? Yeah, and the enzymes, right? You have no enzymes, so you're going to be on enzyme replacements the rest of your life. And that sheet that she had will be helpful to you on how to do that. Yeah, so that's going to be like, people that just like get like their thyroid removed when they have that, is it Hashimoto's, I think. Mm-hmm. They get their thyroid removed and they have to be on thyroid pills the rest of their life, which, if you're dealing with cancer or take a pill the rest of your life, that might not be a bad option. So the only thing that's like not the greatest is that successful surgical intervention and chemo can prolong life for 5 to 6 years. And I'm like, that doesn't seem worth it to me. I'd rather just be like, huh? Yeah, I'd be like, that's a lot of money to have my family like be stuck with after I'm gone. So that's just me. Huh? Yeah, I'm sure. Like chemo is always hard. What'd you say? Just a pancreas. I'm talking about total pancreatectomy. That's what. Yeah, just taking the anything that's ectomy is removal of tonsillectomy, whatever else, ectomy, pancreatectomy.
When you say total, you're able to remove part of it and be fine?
I don't know.
Oh, okay.
I guess if you just have a really diseased portion, you can cut that part off. But if you're worried about cancer, you probably just take the whole thing out. The problem is that it comes back a lot, and a complete cure is super rare, super low, and the cancers frequently come back. I don't know if she has it. What's your name?
Cindy.
Cindy, do you have anything to add on that?
It's not caught in stage 1. It's very much terminal.
Okay, well, there you go.
It's very rare that it's caught in stage 1.
Yeah, because what kind of symptoms would you have?
They're very, very vague.
Yeah.
Usually it's only found by scan by accident because you're having another problem.
So just in case this didn't pick up what you said, I'm just gonna repeat what you said, that if it's not caught stage 1, it's pretty much terminal, and that signs and symptoms are very vague in stage 1, very hard to find unless it was found incidentally. So yeah, I'm just like, you can do all this, have this surgery, go through all this. And I'm like, for 5 more years doesn't seem worth it to me. I don't know if that was on here. She said 23% survived the first year. So that's already very small. 5% survived 5 years. So yeah. This is actually good. It says state 2 major reasons for delayed diagnosis of pancreatic cancer. Again, vagueness of signs and symptoms. Like, okay, I have nausea, vomiting, bloating. That's just, I get bloating, whatever. Like GI stuff is always like, it could be so many different things, right? So like, you're going to go to the doctor every time you feel bloated? No. Usually diagnosed late in the disease process by the time it's like really bad. And then usually by that point you have like liver and gallbladder involvement because it's spread and it's all over. So it's like, well, like you said, terminal. What else? Where is metastasis likely to occur? Obviously anywhere in the abdomen. So stomach, gallbladder, intestines, duodenum, liver. So liver's
number 1 where it meant to.
Yeah, just it's neighbors, right? What else? I'm going to skip that one. What are the risk factors? We kind of talked about that one already. Cigarette smoking. Yeah. High fat diet, which makes sense because it's, the lipase situation. We're talking about remember earlier, we're talking about the steatorrhea and the fat malabsorption and, the red meat, processed bacon, all that stuff. It's hard on your digestion. So high fat diet, red meats, fried foods, refined sugars, all that stuff. And those are things you can do something about, what they call modifiable risk factors, right? You can't modify your age, your sex. Well, I guess you can now. Anyways, or
You can't alter genetics.
You can't alter your DNA, okay? I said it. Or I said it. Or your race, right? You can identify as whatever, but your DNA is your DNA. So you can't change those, but you can change what you eat. Don't smoke and don't drink alcohol. Likely clinical manifestations, we said pain. Pain is number one. Jaundice, we mentioned, related to the obstruction of the bile duct. Weight loss, which we mentioned, which is more indicative of like chronic, right? You're not going to have major weight loss from an acute episode, right? It's just because it's just an acute episode. Which lab values, we kind of looked at this one already. So the lab values are going to be similar with pancreatic cancer, what we talked about earlier. Increased amylase. You're going to have an increase in LFTs. Do you guys remember what LFTs are? Isn't that like the, yeah, the ASTs and ALCs and all that stuff? Yeah, increased lipase, increased trypsin, all those things that we kind of mentioned before for the acute. It's going to be very similar. The pancreas is in distress. Labs are going to look kind of the same, right? Is that helpful? Let me get this back to you. Okay, so that was a total pancreatectomy. The other thing is called a Whipple procedure, WHIPPLE. Let's see if I can kind of draw that. Let me erase this. Okay, so the Whipple procedure is very weird. So what they do is they remove the head of the pancreas. You remember the part that was down here by the duodenum, the big ball part? They remove that. They remove part of the duodenum, part of the jejunum, and part of the stomach. So they just remove a lot of stuff. And so what it ends up looking like is this. Let's see if I can draw this. Okay, so this looks weird, I know. Okay, so this is the gallbladder. So that's there still. This is the pancreas over here, the thing that looks like a corn. They just chopped off the part that was like this part down there. Remember, that was the head. They chopped that part off. They got rid of part of the duodenum. And now this part is the jejunum. And then the stomach, you'll see, is now connected here, right? So it's kind of like you know how the GJ tube worked? It brought the tube went from the stomach into the jejunum. It's like a permanent version of that, where now you have the stomach going straight into the jejunum. So it's like a very drastic GJ tube. That's literally what it is, right? So, and I guess that's, you know, if they have the cancer, that's, you know, they're removing that part of it and just bypassing all of that whole system and just going straight to the jejunum. Have you ever seen any of this stuff?
We probably seen 5 with the Whipple procedure.
Okay. Now, if someone does have a Whipple procedure, there are a few like patient care things you need to know. Obviously, for a while, they need to be NPO, right? Because a lot's happening, and you can't just dump food into like a fresh surgery that's with their stomach, right? So they need to not be on that. They also need to be on some low suction, you know, the suction on the wall, like the wall suction they have, like you're gonna have it on low suction, just because like the stomach is probably gonna still be bleeding from the incisions and stuff. So just, you know, pulling out any bleeding that would be doing that, any like secretions or whatever, to keep it, to give it some rest. And you don't want any increased pressure of like buildup of fluid sitting there, because it can burst the sutures, right? So another reason why you don't want to eat, you want to keep no pressure in the stomach at all while those sutures and stitches are healing, right? So checking the tubes, drainage, checking their blood sugars, which is kind of the same stuff for what you did before anyways, and just checking electrolytes. So the big thing is the suction and NPO. So your notes said low intermittent suction. Mine said low continuous suction. That's why I just said low suction. But your notes say intermittent, so go with that. But yeah, does that make some kind of sense? This is the Whipple. I've never seen one. I've heard of it, but that's about it. That's pretty much everything with pancreas. Any overarching questions or any handouts that you have that I didn't comment on? Yeah, they both will. It's just, yeah. Because the pancreas is the one that like helps with that. And so any issue with the pancreas is going to have low.
So the only different thing we talked about, like the steatorrhea, malnutrition, weight loss.
Yeah, it was all the things I had written on this side, which was the chronic. So
That
this
separates chronic and cancer.
chronic and acute. But chronic and cancer are gonna look very similar because it's basically the same thing. You have chronic pancreas problems, right? But again, it's gonna be more like late stages because the early stages, like you said, you don't really have a lot happening because it's slowly developing. So late stage, I would say, correct me if I'm wrong, like more late stage would look more like a chronic pancreatitis. But again, chronic pancreatitis can lead to cancer. So it's like,
Yeah, they're both the same.
Yeah.
When I Googled the whole why do you have the low calcium?
oh,
it said,
perfect.
It can be pancreatitis can be associated with tetany and hypocalcemia. It's caused primarily by precipitation of calcium soaks in the abdominal cavity, but glucagon stimulated calcitonin release and decreased PTH secretion may play a role.
That just went right
So
over.
someone with parathyroid?
Yeah.
Yeah.
It just causes low calcium. Okay. It just,
I don't
yeah.
understand it anymore.
You don't need to know why, so just accept it and move on. That's where I'm at with that. I'm gonna push pause on this for a second.